Hello and welcome to the Bernard van Leer Foundation's webinar on the theme of responsive parenting. This is following up on the June 2014 edition of the journal Early Childhood Matters. We're very happy to have with us the authors of 3 of the articles from that journal. Jennifer Lansford joins us from Duke University in the United States, Adrian Burgess from the Fatherhood Institute in London, and Cathy Ward from the University of Cape Town. Each of them will present for 10 minutes, then we'll have a 30-minute opportunity for question and answers. You can ask questions at any time during the presentations by typing them into the questions box that you should see on your screen. After all the presentations, I will then go through the questions, posing them verbally for everyone to hear and for the presenters to respond. So now to our first presenter, and I'm very pleased to introduce Jennifer Lansford to talk about the Better Parenting Programme in Jordan. Over to you, Jennifer.
Thank you, Andrew. It's a pleasure to be here today to speak on behalf of my colleague Suha Al-Hassan, who's at the Hashemite University in Jordan. And we'll give a very brief overview here of the context in Jordan, which, as you'll see here from the map, is in the Middle East. It is a country with about 6.5 million people. It's 90% Muslim, and the main language is Arabic. And I'll show you just a couple of pictures of what things look like in Jordan to help you get a visual in mind. So this is the city of Amman, which is the capital and largest city in Jordan. And it has some beautiful touristic spots, including Petra, which is one of the 7 wonders of the world, as well as the Dead Sea, which is also quite a beautiful spot. So just to give you a couple of images that you can keep in mind as we're talking about the context in Jordan. So over 50% of the Jordanian population is under the age of 18, and almost 20% are under the age of 8. So it's a very young country. The national average of children per household is 5.6, and only half of Jordanian children attend formal preschool, and less than 5% attend any form of daycare. So the majority of young children are cared for at home. This is primarily by their mothers. So it makes the context of improving parenting and making sure that parenting is as optimal as it can be, especially important in Jordan. So going on, the Better Parenting Program was targeted at both urban and rural families throughout Jordan, especially families who were disadvantaged by poverty, unemployment, and low literacy and educational achievement. And the program was aimed at providing parents and caregivers with skills and information to enable them to promote the psychosocial, cognitive, and physical development of their children between the ages of 0 and 8 years. So the program took a child rights-based and holistic approach to children's growth and development within the context of the family and the community, and put special emphasis on increasing the role of fathers in child rearing. So moving on. As you'll see from this organizational chart, there were many government agencies involved with this work, including the Ministry of Health, the Ministry of Education, the Ministry of Social Development, Ministry of Islamic Affairs, as well as several NGOs and the United Nations as well. So this was really a multi-sectoral and kind of broad-ranging intervention. Moving on. The Better Parenting Program consisted in total of 16 hours of lessons that focused on specific areas of parenting knowledge, attitudes, and behaviors. And there was quite a bit of flexibility in this program for variations from site to site to meet the needs of local participants. But lessons were led by social workers, health workers, kindergarten teachers, and paraprofessionals who'd been instructed by centralized trainers. And the facilitators' manuals, so the manuals that were provided to the people delivering the program, included session guides, audio-visual materials, parent activity sheets, take-home materials for the participants. So the leaders were provided with quite a range of different kinds of materials that they could do both during the sessions as well as sending home with the parents. And moving on. The structure of the program followed kind of a trainer of trainers model. So UNICEF was the umbrella organization through which this was conducted. And then there was a kind of a pyramid structure going down from there with centralized trainers who then trained local facilitators who were the teachers and paraprofessionals who actually delivered the program to the beneficiaries, who were primarily mothers, but also included fathers and other caregivers as well. And moving on. I want to highlight a little bit the efforts that the program made to reach fathers, because fathers are oftentimes neglected in these kinds of interventions, as you'll hear more about later during the webinar. But one of the challenges faced by the Better Parenting program right from its inception was the difficulty in reaching fathers. So on reflecting on places and times that men could be reached in Jordan, it became clear that mosques were an ideal space for Better Parenting sessions. Most men in Jordan go to the mosque regularly for Friday prayers and give a lot of weight to the preacher, the Imam, who's highly respected within the community. So there was an effort to try to use this context to try to reach fathers. So moving on. UNICEF produced an Imam guide on early childhood development so that imams would receive training on ECD issues over a 6-day period with then additional resources for sermons mailed to them monthly. And this training guide included ideas about the role of fathers in children's lives, ingredients of a successful and happy family, equality between genders in raising children, the impact of marital discord on children, and strategies to reinforce healthy communication in families. So that I'll not say too much more about the role of fathers at this point, although I'd welcome questions and discussion about that later on. But I did want to highlight that that was an important part of the Better Parenting program. So moving on. I think another key aspect of the Better Parenting program was not just the program itself, but the evaluation of the program. So very often, parenting interventions are implemented without building in an evaluation component. So if that's the case, it's not possible to determine whether the parenting program is having any beneficial effects at all. So I think that the organizers of the Better Parenting program had a lot of foresight in building this evaluation into the program. So the evaluation involved 337 parents and other caregivers who were randomly assigned to an intervention group that participated in the Better Parenting program or a control group that did not participate. Both groups completed questionnaires before and after the intervention group participated in the Better Parenting program. And moving on, I'll highlight just a few select findings from the evaluation. So participants who were in the intervention group, but not the control group, improved on parenting knowledge, spending time playing and reading books with their children, using more explanations during the course of disciplining their child, and accurately perceiving behaviors that would constitute neglect. And these were all attitudes and behaviors that were the focus of different lessons within the Better Parenting program. So there were also some things that didn't differ between the intervention and the control group. So an example there is that both groups increased in using positive discipline methods and decreased in using negative discipline methods over time. And I think both of these kinds of findings highlight the importance of using these randomized randomized evaluations with both pre and post testing, because it makes it possible to see, for example, that you couldn't necessarily conclude that improvements in discipline were a function of participating in the evaluation, but maybe were more a function of thinking about discipline just by virtue of being asked some initial questions about how are you disciplining your child. It might have prompted parents in both the intervention and the control group to think more about their discipline and maybe make some changes accordingly. So moving on. Some conclusions that we could take away here. Overall, the findings revealed small effect sizes. So these are not large differences between the intervention and the control group. But there were several areas in which there were small effect sizes in which the intervention and control groups differed. And so that, I think, also highlights the importance of these intervention evaluations. Even on the pre-questionnaires, many parents reported positive behaviors and good parenting knowledge. So the Better Parenting program can build on those strengths rather than taking a deficit approach. So starting with the assumption that parents do have strengths to bring to these programs and then working from there. Because the Better Parenting program has been implemented widely in Jordan, even small effects within individual families may amount to large effects for Jordan as a whole. And I think that also applies to other parenting programs as well, many of which are implemented quite widely and are available at different national levels. So all of this is to say that that the Better Parenting program did show some promise. And I look forward to hearing the other presentations and being able to address questions that you may have about the program in Jordan when we have a chance for discussion and questions later. Thank you.
Thank you, Jennifer. And just a reminder that you can ask questions at any time by typing them in the questions box that you should be able to see on your screen as part of the webinar software. We will collate those questions and use them to start a discussion after all of the presentations. So the next presenter is Adrienne Burgess. She's the Joint CEO and Head of Research at the Fatherhood Institute in the United Kingdom. And we're very pleased to welcome you, Adrienne. Away you go.
Thank you. Good afternoon. It's a great pleasure to be here, and we could go on to the next slide if you like straight away. I want to talk about, it was also good to hear Jennifer, because I have reviewed her program and her excellent evaluation when we've looked, as we have done, at parenting programs internationally that include fathers. So I want to start with a sort of why have we bothered to do this, which is that it has been learned now that the systematic overlooking of fathers and father figures in services that engage with families has very detrimental effects. In real crisis situations such as child protection, it is connected with increased child abuse and deaths, because the professionals tend to engage mostly with the mothers, make them responsible for protecting their children and introducing and maintaining change. Father's behavior is often, and father figures' behavior is often not addressed at all, and potential resource dads, dads who, and father figures who have stuff to offer, are often not listened to. So that's really quite a dangerous area. But there's even in other areas where it's not so dangerous, overlooking fathers is problematic. So, for example, in breastfeeding, if you actually engage specifically with the dads, thinking about targeting material to them, reaching out to them, meeting them, and we'll talk about how to do that in a minute, then you find that the mothers are more likely to initiate breastfeeding and to breastfeed for longer. So moving on, please. What do we know from this big review that we've done of parenting programs internationally that have engaged with fathers? And I'm talking about interventions now that seek, like Jennifer's does, to improve parenting skills one way or another. So the evidence base on the dads is poor. I mean, Jennifer already mentioned that a lot of parenting programs don't have any evaluations, or even very good evaluations, even if they do have evaluations. It's even more the case with ones that engage fathers. Partly, and this was the case with Jennifer's, because of the problem she had reaching the dads and trying to think of strategies to do that, the sample sizes of participating fathers are small. So drawing conclusions from that can be difficult. Even where you've had substantial numbers of fathers engaged, it's amazing that evaluations rarely disaggregate outcomes by sex of parent. And the other interesting thing they don't do is they don't disaggregate by whether both parents or one parent attended the session. So I think that's a real problem, because it actually skews your findings. If you, for example, have a group of 10 people, of whom 3 are couples, and you have good outcomes, and you think it's because it's the parenting program, it could be because so many of the people involved in the session were both receiving the information, because evidence does suggest that if you engage both parents, they're more likely to hear what you say and able to implement the changes quicker, and the changes are likely to be maintained. Moving on, please. So how do we have strategies to get more fathers through the door? Firstly, you have to have your recruiters trained in father inclusive practice, what we call father inclusive practice. They have to be trained, and the systems within the agency have to be developed to engage with fathers wherever they go. So, for example, if you're having a home visit and you expect to see the mum, in your preliminary phone call or letter, you say, "We do hope to meet you both." And you try to negotiate a time that will be suitable for both parents. And we find that when people do that, very often fathers can be flexible at work. Some flexibility is sometimes they work shifts. There's all kinds of ways in which they can attend. And just that invitation, we hope to see you both, makes a huge difference. So you're not having to go out to the mosque or go out to the working man's club or go out. You're just going to where you go, but making it clear that the fathers are to be invited in. Adopting what we call a gender-aware approach is important. So you might think, that with the sort of outcomes they were looking for in better parenting, that what they want is you're teaching parents the same thing. So why do we need to have a gender-aware approach? Well, the answer to that would be that though you are teaching the same thing, very often mothers and fathers come with a sort of different attitudes, different social scripts that will inform how they hear, where they find their problems. So, for example, fathers may want to approach discipline in a more authoritarian way because they believe that accords with masculine identity, and they should be doing that. They may not want to do it, but they may think they should somehow do that. So you need to have those conversations, and it's great to have the conversations with both parents about this. You need facilitators who are trained to engage with men. It sounds sort of so obvious, but it almost never happens. We do a lot of training, and we train mostly women, of course, because they're in services. And it's amazing how many really aren't confident. They think they really can't engage with men. They say, oh, well, can't we get a male worker? And we go, no, you can't. That's not what it's about. You're going to be going out in your normal practice and engaging with men. And I tell you, you can turn them around in 2 hours from thinking that they can't to recognizing they have all the skills they need and that they can do that. So moving on, please. Now, what about men-only programs? Now, I'm not saying they're never suitable. I'm just saying they should be a last, not a first resort. Really should explore the idea of engaging men and women together, or the couple together if you're doing individual work, before trying to shunt the men off to some men-only group. Partly, you will get very small numbers when you try to do that in most contexts. A very tiny percentage of dads will be willing to actually go to an all-male group. And the other problem is that when you have a men-only programs, even if they are working quite well, they're the first thing to go when resources are scant. And the other reason is going back to this idea that you really do need to help both parents think about father's involvement. You really do, because you can skill the fathers up all you like. And if he goes home and she blocks it because she doesn't understand it or she feels nervous, you've wasted your time. So, for example, I saw a program in South Africa that, among other things, was trying to encourage the dads who had access to parental leave to take parental leave. And they found one mother, for example, who was very upset by this because she thought that her partner wanting to take parental leave meant that he thought she wasn't a very good parent. So that's why you do need to engage the women as well as the men. Moving on, please. We have 92 programs in an article that is published this week in the Journal of Child Psychology and Psychiatry, which is referenced in the article for Early Childhood Matters, where you can see all the 92 programs that we found. I'm just going to take 3, and these are all in the Early Childhood Matters article too. So the first exemplar is a universal service in hospitals throughout a region, where they informed all new mothers and fathers at the time, before the birth, round the birth, about the risks of shaking babies, and they gave them strategies to deal safely with triggers such as persistent crying. I think the most important part of this intervention is that they were to sign a commitment statement acknowledging receipt and understanding of the information. And the fathers signed it separately from the mothers. They each had a commitment statement. And there was a real effort to get both parents, which you normally can do because most of the fathers are at the birth. A video was also produced, but it wasn't widely recalled, and they think that's because probably the midwives didn't show it to lots of the parents. The outcomes were good. Rates of abusive head injuries among 1 to 3-year-olds were down almost 50% over 5 years. Moving on, please. Right, this is another UNICEF program. This is the Papa schools. And I think, so here we have the Ukraine, where they did the evaluation here. Again, this is across the transition to parenthood. But sessions before and after the birth. And you can see the kind of topics that were included, which included the importance of fathers. And I do stress this is something that mothers as well as fathers need to hear. Again, you have very good results. Father's birth attendance up, child morbidity down, postnatal complications down, childhood trauma down. Moving on, please. Right, the third and final one I'm going to talk about here is another transition to parenthood one, but it's different. This is in the US. It has homework, it has video and online resources. And what's interesting here, it's the most active program, parenting program I've ever seen. We've trialed it in the UK where it's gone well. It's both parents, it's a co-parenting program. It looks at co-parenting, how they support each other. It's not just about the individual dyadic relationship and interactions between each parent and child, which is what you normally have in parenting interventions. This is about how they support each other or undermine each other and where they're coming from when they look at, where do they come from with discipline? What do their families of origins teach them? And so on, so that they learn how to work together, because we do know that the quality of co-parenting is an independent predictor of positive or negative outcomes. So moving on, just want to finish off with a few little sort of strategies, if you like. Look, most parenting support for mums is not formal programs. It happens when the midwife has a conversation with her, or the post-birth nurse, or the clinic worker, or the nursery teacher, or the social worker. It's individual conversations, and it's how you have those conversations with fathers, or how you have those conversations with mothers about fathers. That is part of father inclusive practice. So if a dad's in front of you, how can you informally support him without sending him on a program? You can suggest the following. You can get him to hold his infant close for long periods. If a man holds a baby for 15 minutes, doesn't have to be a parent, just any man, holds an infant for 15 minutes or longer, physiological changes start to happen in the body. They have an increase in the breastfeeding and other hormones that women experience, and they have decreased in testosterone. And this is a very powerful way of, as it were, inducing parental sensitivity. And if men miss out on this close care, just as if women missed out on it, a lot of physiological changes wouldn't happen. So it's very important just to encourage the dads to hold their babies. Encourage them to recognize and respond to infant cues, smiling, poking out of tongue, looking at, mutual gaze, all those things. The dads love that if you help them do it and help them understand why it's important. And so why is it important? Well, you say to the dads, there are really two important things here. Firstly, it actually helps your baby's brain development, the synaptic pathways. It helps develop those, and they love that. It helps you make a smarter baby. And the other thing is that if you create these bonds very early on, you're setting the stage for helping your child through adolescence, because an empathic and close relationship with their dad from the beginning is likely to do that. And the research shows that fathers very early on are worrying about adolescence and whether their kids are going to go off the rails. So helping them make that connection between making the connection with their infant now and what will be happening in 13 years' time is valuable. The last point here, which is that they should be encouraged to look after babies on their own. You really do want mums out of the way so the fathers can develop their own ways of doing things. And now moving on. It's not only men who need to change. It really is the staff and managers need to have the strategies to know how to bring the fathers in, but they also need to believe it's important, otherwise they won't do it. And that means exploring their own attitudes and beliefs, reviewing their existing practice, and developing systems that include fathers, so requiring them to gather the information, the father's name, his contact details, his strengths, the challenges he faces, and of course to evaluate. And now, finally, On to the next slide. Our resources. We've created at the Fatherhood Institute, funded by the Bernard Van Leer Foundation, some lovely resources, topic sheets backed by research summaries that give you the strategies, very easy to understand, print off, post up, use discussion documents in meetings. And we can back those up, of course, with training, and that is the name Cathy Jones of our training manager. Thank you very much.
Thank you so much, Adrienne. Just a reminder, you can type questions at any time in the questions box. We will get onto the questions. We'll get through as many as we can after the next and final presentation. And it gives me great pleasure to introduce Catherine Ward, who is at the University of Cape Town. She'll be talking on the Parenting for Lifelong Health programme. Cathy.
Thanks very much, Andrew. And really, the Parenting for Lifelong Health is the name of a group of programs that I'm working on with a much larger group that I'll introduce you to in a moment. And the focus of this is really reducing violence against children through parenting programs and working particularly in low and middle income countries. So two questions really spring to mind. Why parenting programs to reduce violence, and why low and middle income countries? The first is that rates of child maltreatment and childhood adversities, which are things like losses of parents or parents with mental illness, are high in low and middle income countries, on average higher than they are in high income countries. And these things have serious lifelong consequences for those children, often in terms of mental health disorders, which is probably fairly obvious, but also in terms of physical health disorders. So chronic disorders of lifestyle like obesity have also been linked to child maltreatment. And children who experience these things are not only struggle with their health, but also tend to struggle with education, and that reduces their chances of getting a good job. They're more likely to end up in the prison system. And so there's a very high cost to society, in the one hand, in treating things like mental and physical health disorders, or in containing people who have become violent in the prison system, the justice system, but also in children who underachieve and perhaps don't get well-paying jobs that allow them to give back to the tax base. So there really are good human rights reasons for looking at these things, but also in terms of sheer economic cost, it's important to look at them as well. Now, parenting programs are very promising in terms of reducing both child maltreatment and later youth violence, in fact, and child maltreatment tends to put children at risk for later youth violence. So that's another reason why we are focusing on child maltreatment. But many parenting programs that are currently available and that have a strong evidence base are beyond the reach of many low and middle income countries. South Africa is an upper middle income country. When we were looking at parenting programs to do this here in the Western Cape province, we ran it past our provincial government and they said, very sorry, but too expensive for this context. So that kind of confirmed for us that this was too expensive. Now, there are many reasons why programs have chosen to take a proprietary route, and often that's around protection not only of the intellectual property, but also protection of the fidelity, so that if a program is being implemented under particular labels, so for instance the Good Parenting Program, it's a name I've just made up, that what is being done under that label is being done faithfully to the model that the program designers developed, and that means that people need good training and good supervision, and that costs money. So there are good reasons why people have gone for a proprietary kind of model. But it does tend to put it beyond the reach of most low and middle income countries, particularly when we start talking about taking things to scale. There are also issues around cultural appropriateness. Some studies show that programs that have been developed elsewhere, and most programs have been developed in the US and Australia, and often tested in those two countries and in the UK. So we've got very few programs that have been developed and or tested in low and middle income countries. So some programs do transfer very well, and we get very good effect sizes with a program that has hardly been adapted at all in low and middle income countries. But we also have programs that have been very carefully and thoughtfully adapted and fail. So there are issues about cultural appropriateness. But at the same time as we have these sorts of barriers to rolling out the evidence-based programs quite widely, there's a big demand from countries who are concerned about their high rates of child maltreatment and other related problems, and also from the international organizations that are working in those countries. So the bottom line is that really we don't have at the moment known evidence-based affordable parenting programs that are appropriate for rolling out, particularly to scale in low and middle income countries. Next slide, please. And I just briefly mentioned to you that the Parenting for Lifelong Health team comprises both the World Health Organization and UNICEF, as well as a number of universities, all of whom we knew about each other's work, but coincidentally realized that, of course, we are all working in South Africa. And so that was part of the impetus for looking at this, so that South Africa would be, as it were, the cradle for these parenting programs. And as we establish evidence, we'll be taking them to other countries. Next slide, please. So the aims of Parenting for Lifelong Health really are to develop, test, and disseminate a suite of parenting programs across 3 age groups. We actually have 4 programs, which I'll introduce you to in a moment. 2 aimed at the infant age group, sort of 0 to 23 months, then 2 years to 9 years, and another for 10 to 17. They're specifically designed for low resource settings. So we are working with paraprofessionals, community members that we select and train up and provide quite a bit of supervision for. And who are doing really good work. And we also do other things as well. So for instance, a number of parenting programs rely on video materials, but in some of our contexts, either there's no electricity or there isn't access to a DVD machine. And so we're using materials such as cartoons, little scripted stories that can be acted out or read with parents and that parents can relate to and that make the same kinds of points that a video vignette would make. The goal is to prevent violence, child maltreatment and later youth violence, and to promote early child and youth development. So we do have an emphasis on the positive as well. We're making them affordable. The organization that will oversee the training and the fidelity issues will be set up on a not-for-profit basis. And as both Jennifer and Adrian have said, what we do needs to be based on rigorous evidence, because even more so than in high-income countries, low and middle-income countries can't afford to waste money on programs that aren't achieving very much or, in fact, may be doing some harm. We'll be licensing the programs through the Creative Commons, which will mean that the program materials will be freely available, and our intellectual property will be protected, but they will be, the materials will be available free, and we are putting in the provision there's a Creative Commons license which stipulates that you would be allowed to use the materials but not allowed to make a profit out of them. And we hope to set up a dedicated fund for training and adaptation, because fidelity of program implementation is really critical, as well as establishing the initial evidence base. Next slide, please. So we're looking at the core principles of our programs, taking a collaborative approach to problem solving, so parents would be encouraged to identify their own goals and to work towards those goals in either the home visit-based programs or in the group-based parent programs. Emphasizing increasing positive parent-child interactions and improving emotional communication skills, both for parent and for child, along with helping parents manage themselves, their own emotions, so that we are setting the grounds for self-regulation in children as well. Emphasizing positive discipline practices, including consistency, establishing clear limits, house rules, appropriate supervision, the kinds of things that do protect children, particularly as they get older. Use of non-violent means of discipline is particularly important, and that would include a huge emphasis on praise and rewarding what you want to see, as well as planned ignoring, time out, and that kind of thing. We have a big commitment in our programs to ensuring that the parents practice new skills. So we do a lot of role play, a lot of coaching. We'll do home visits if parents are having particular problems, even though most of our programs are group-based. And so we really give parents a lot of opportunity to practice this in the real world of their own families. We emphasize culturally sensitive forms of communication and interaction, the importance of child-led play and praise. I've talked about parental self-management, but we also build in some mindfulness-based stress reduction techniques, because many of the parents that we are working with live in very difficult contexts where they themselves may be poor, their neighborhood has very few resources, it may be a very violent neighborhood. And so stress relief is actually quite important in helping parents manage the parenting behaviors. And then what we also are doing, particularly with older children who may have very difficult or traumatic experiences, in our earlier work, we've come across instances where children have, for instance, been raped. They come home, disclose to parents, and are met with quite a blaming response, which of course is not helpful to anybody. So training parents to respond empathically and sensitively to difficult or traumatic child experiences. Next slide, please. So we have Peerled for Infants, which is a home visiting program where our staff will work with pregnant women up until the child is 6 months old. And it really aims to build attachment between mother and baby, as that's a ground for preventing child maltreatment and also giving the child a good sense of what a good relationship is all about. The initial program was called Tulisana. Tulisana is an isiXhosa word, which is the local language in the Western Cape Province, indigenous language, and it means hush little baby. And it was evaluated in a randomized controlled trial in Cape Town, and the evaluation found that mothers were more sensitive and less intrusive with their infants, the infants were more securely attached, and mothers were less depressed in the experimental group at 6 months. I'm just going to say we can't do this work without donors, without implementation partners, and so on each slide I've included the donors, and at the end there's a long list of other people we need to thank, but I do just want to say thank you to everybody who has made this work possible. Next slide, please. Then we have PLH for 14 to 16 months, probably could target a slightly broader age band, but this is a fairly new trial that our colleagues Mark Tomlinson and Peter Cooper and Lynn Murray have just finished. They were using a dialogic book sharing approach, which is really about cognitive stimulation for children, and there's evidence from places like Jamaica which shows that children who have good cognitive stimulation in the early years are less likely to be violent at the age of 20. So that's what we're hoping for. Of course, these children are still quite young, but they did show improved vocabulary and sustained attention, and we're looking towards building that into a more extensive parenting intervention, which would also include the kinds of behavioral work that we are working on in the older age groups. Next slide, please. So PLH for young children, which is the 2 to 9 years old program, really does focus on managing children's behavior in positive ways. We're calling that here the Sinevuyo Caring Families Program. Sinevuyo is also an isiXhosa word, and it means we have happiness or we have wellness. So it's really expressing that families are aiming towards something really positive, that the whole family will be well. It's a 12 to 15 week program. Groups meet weekly for 3 hours. In between, we do home visit consultations to support learning. So if parents miss a session or they're having trouble with a particular skill, our group facilitators will go out and visit them and work with them. And a lot of emphasis on role plays so that parents really do take the new behavioral skills on board, and on group problem solving so that parents learn to think from a problem solving perspective, so that when the group is over, they've got tools for thinking things through that might be novel. Last year we did a small RCT with 68 families and showed that this was feasible, it was culturally acceptable, and we had improvements in positive parenting. And this year we're doing a much larger RCT. We aimed for 180, but actually thanks to some of our extra funding, we're probably going to be able to reach 300 families, which is a very, very nice size for an RCT, and so we'll be able to do quite detailed analyses of our results. Next slide, please. So the next program is the one that's aimed at parents and teens, and there's quite a bit of data from the US and from South Africa which in fact shows that child maltreatment goes up in the teen years. And so we have a primary goal here to reduce child maltreatment in the home, but also to improve family capacity to protect children from abuse risks outside the home. Because parents really do get very worried about their adolescence, as was mentioned earlier. So we do sessions, it's also 12 sessions long, where the parents and the teens are either receiving parallel training and then sometimes come together to practice those new skills together. We're testing this in the rural Eastern Cape of South Africa. 2012 we did extensive consultations, quite a bit of qualitative research, and we're fortunate to be able to work with NGOs in the Eastern Cape to do a preliminary pre-post which had really very positive results. Positive parenting increased, violent discipline went down, teens were much more positive about their parents, so really nice outcomes there from a very small pre-post. We did need to make some adaptations to the manual, so we've been working very hard on the manual, and next week we'll be starting with our pre-post pilot testing with 100 families. And once we have done the final adaptations to the manual, we'll go into a randomized controlled trial with a much larger group of families. Next slide, please. So the next thing is, once we have some evidence from South Africa, and probably from pre-post trials will be, if we have some positive evidence, we hope to adapt and test in other countries, again with a pre-post and then a randomized controlled trial, while at the same time we need to establish an entity that can manage the training, the supervision, the cultural adaptation around the world. Next slide, please. So this is the slide where I thank the cast of many, many people who have been wonderful implementation partners and have been willing to sit down with us, think things through, problem solve with us. So I wanted to say thank you very much to everybody here. And next slide. And then just to leave you with a wonderful picture, which is a real-life picture. This is a grandmother caring for her grandchild who went through the Sinovuyo of Caring Families program for children aged 2 to 9, and that smile on her face is what it's all about. Thanks very much.
Thanks so much, Cathy, and thank you everyone for the questions that are coming in. We'll move on now to the questions. We'll try to get through as many of them as possible, but rest assured that if we don't manage to get to your question, we will forward it separately to the authors afterwards. And also, just to say, in response to one of the questions that's come in, we will be sharing the PowerPoint and we'll also be sharing the recording of the webinar on the Bernard van Leer Foundation website in the next day or two. So let's start with a question for Jennifer, and this question's from Eric van der Waal. Jennifer, what implications do cultural differences have on the Better Parenting Programme in terms of any contrast between Western thinking and Islamic thinking?
It's a great question. I think that any of these programs that we've been talking about, I'm sorry, certainly need to pay attention to cultural issues. And I think one of those has to do with framing issues within a way that is locally accepted and endorsed. So in the Better Parenting Program, one of those examples was attempting to reach fathers through the mosques and using the imams as the people who were delivering the program, because culturally in Jordan, fathers were much more open to receiving these messages from the imams than they were from receiving them from kindergarten teachers or other paraprofessionals. And in part, that was because the imams were so respected by the fathers in that context. I can give a couple of other examples. Maybe from outside of Jordan. In some cases, it's a matter of slight reframing in messages that can help things to be more locally acceptable. So there's some evidence from India, for example, that ideas having to do with child rights are not widely endorsed in India. So a parenting intervention that emphasizes children's rights isn't as well received as a parenting intervention that emphasizes parents' responsibilities to children. So even if overall many of the knowledge and attitude and behavior goals are the same, framing the message within a context that is more widely endorsed by a given cultural group can help the message be better received. Hope that helps.
Thanks, Jennifer. Cathy, we had the same question for you. You talked about culturally sensitive forms of communication. How do you go about ensuring that, Cathy?
Well, I think there are several things that we have done. One is that we work with our group facilitators, our members of the community, and they can alert us to anything that's likely to be culturally inappropriate. They, in fact, we wrote the manuals in English, but they translated them for us, so they make sure that everything is couched in terms and in phrases that would be culturally appropriate, and we work with them to make sure that the concepts are right, but the language is being translated well. And then we did quite a number of focus groups and individual interviews with parents and talked to them about the kinds of things we were thinking about, got their feedback. And in the first run through the program, we then did again extensive focus group interviews, individual interviews, saying, did anything not sit well with you? And in fact, to our surprise, we found that everything that we had proposed, even if it was novel, parents did have a little bit of difficulty learning about timeout. So we put more effort into that in the program the second time round. But the concept itself, nobody said, this is awful or it won't work in our culture. That's really been our approach. Thanks.
Thanks. Adrienne, do you want to come in on the cultural issue? And we also have another question for you, Adrienne, about self-selection bias in the samples of fathers. Do you think it's a problem that only fathers who are already interested tend to be studied in these programs, or are these interventions that would work with any group of men?
Oh, I don't think that it's only fathers who are interested. I think it's quite often yes, they are quite often. If you look, for example, at the Head Start sample, one of the Head Start studies, the fathers who were partnered, who were therefore, were in a relationship with the mothers who were already attending the program, tended to be the ones who took part. So in some settings, it will be more advanced, not more necessarily
Muted.
I don't think they were that advantaged, but slightly more within the context of the group that's being targeted. But often these programs are being run with very low income groups, so we're not talking about nice middle class dads showing up. And sometimes, of course, they are with fathers in prison. So quite a few programs have been run with imprisoned fathers, and you do see that they're human beings. They benefit from an understanding of child development and from understanding what their role may be. I don't think that there's any particular reason to think that these programs would not be effective with all fathers any more than they would not be effective with all mothers.
Unmuted.
Thanks, Adrienne. Another quick question for you from Jens, which has just come in. Jens says, I wonder if any of the speakers can say something about work with fathers and teenage sons. This is something that we're developing a method for in the Netherlands, and it would be interested to learn if you're aware of similar projects elsewhere.
Yes, there is a program. If you look at the article in Early Childhood Matters and then go to look at the link, Panterbrick et al. Well, you just look it up now. PANTER-BRICK. It's easy to find. Et al. Journal of Child Psychology and Psychiatry. It'll pick up the article that's published this week, which is on open access. And there are a couple of programs there, I think, one in particular that does look at fathers and teenage sons.
Thanks, Adrienne. Question from Brenda Molloy. The article by Cathy was very interesting. The Community Mothers Programme, which Brenda runs, would have some similarities in being delivered by volunteer mothers known as community mothers using low-cost materials. In contrast, the Better Parenting Programme was delivered by a range of professionals and paraprofessionals, with local facilitators having the flexibility to deliver the programme in a way that works best for the participants. So the question to Jennifer and to Cathy is, to what extent does the who and the how have impact on programme outcomes? Jennifer, do you want to take that one first?
Sure. I think this question really identifies one of the main limitations of a lot of evaluations. So in our evaluation of the Better Parenting Program, we didn't have data that were systematically collected from a large enough number of people to be able to evaluate, for example, whether it made a difference if it was a kindergarten teacher who delivered the intervention versus a social worker or things like that. And I think one of the future directions that's very much needed in evaluations of parenting programs is more attention to these kinds of issues of dosage. So if parents attend X number of sessions, the program works, but if they attend fewer than that, then the program doesn't work, or identifying particular modules. Maybe the content of some modules is really key to the effectiveness of the program, but other content doesn't matter as much. And I think overall, we probably know very little about those kinds of issues, certainly in the Better Parenting Program, but I think in looking at other kinds of parenting evaluations, that applies to most evaluations as well. So that'd be a really important direction for future research.
Thanks, Jennifer. Cathy, do you want to come in on the who and the how question?
Sure. I think one of the things that we really, in low and middle income countries, even in South Africa, we don't have enough social workers to deliver statutory services. We certainly don't have enough social workers to deliver prevention services like parenting programs. So we don't have the luxury of being able to go, should it be social workers and psychologists, or should it be paraprofessionals? There's only one way that we're actually going to get programs rolled out at scale, and that is using paraprofessionals. So for me, the question becomes much more, how do we work with paraprofessionals to support them so that they can do a really good job? And we worked a lot with Judy Hutchings, who has rolled out parenting programs across Wales, mostly using professionals. And her sense was that our paraprofessionals are doing a fine job, but that they did need a great deal more training and support than professionals might. This is, as Jennifer says, this is something that we really have to start interrogating in evaluations, and we need to start studying when is it effective, when isn't effective, how much training and supervision is enough. I think it's entirely possible to do it well. There's some really nice examples of complex mental health interventions being delivered in India, for instance, by paraprofessionals. So I'm certain it can be done. The question is what kinds of support, under what conditions, really. So, thanks.
Thanks, Cathy. Question from Andy Dawes. We'll go through each of you in turn. After Jennifer's presentation, you noticed that there were small differences in effect sizes. And given that this was an RCT with strong internal validity, is there not the probability that effectiveness would be lower once it's rolled out under less rigorous conditions? In general, how large should an effect size be before you think we can have confidence that the programme will make a meaningful difference in real-world conditions? Jennifer, do you want to come in on that one first?
Sure, that's another good question. I think that yes, certainly when you bring a program to scale, you generally find even smaller effects than you do when you implement a program in more rigorously controlled situations. I will note that for our evaluation, this was an evaluation of a program that had already been rolled out pretty widely. I didn't talk about it today, but the program went through a few different iterations before it got to the point that I was talking about today, with revisions to the program and improvements and so forth. So the evaluation today that I was talking about was already of the rolled out program. So I think it was those effect sizes were probably what you'd see as the program continues. Probably we would have seen bigger effect sizes if we had evaluated a more tightly controlled, even preliminary stage of what we did today. That doesn't address, the question of how big an effect size should you get before you roll a program out, which is certainly a good question, and I think it becomes somewhat subjective in the sense of, what do you think, what's the impact you're trying to receive? There's this issue of statistical significance versus practical significance. I wish I had a better answer about kind of an absolute effect size that you should get before you roll something out to scale, but I think it's a complex combination of costs of delivering the program, intended effects, how many people you're reaching by it, and so forth.
Thanks, Jennifer. Adrienne, this must be a big problem with studies of fathers because you mentioned that the sample sizes tend to be really rather low. What's your view on how big a sample size needs to be before we can start to draw reliable conclusions?
I couldn't really add anything to what's already been said. I mean, that is a really big issue, and I would have said that almost none of the programs that have disaggregated findings by gender, the 92. Have a large enough sample size to really say that with confidence. We have among those, I think, 11 or something RCTs, but it's amazing how poor the evaluations are.
And Cathy, do you have thoughts on RCTs and how big sample sizes need to be?
I can't really answer that because I think Jennifer and Adrienne have given really good answers, and I think it's a sort of it depends. I will add that I can think of one example where it's really been done very well indeed, and my sense is it comes down to how carefully you take things to scale. So Marion Forgach has been very involved in rolling out parent management training, the Oregon model, in Norway to scale, and they had a very interesting finding where they had quite robust findings when they trained people in Norway initially who rolled out the program with good effect sizes. Then those people trained a second generation and they got not quite so good effect sizes, which is what you expect. And those people then trained a third generation of folks and they got better effect sizes than the second generation, which I think speaks to probably a kind of care and attention to fidelity. So I think it's probably not so much in how big the effect size needs to be to start with, but how carefully you take things to scale.
Thanks, Cathy. We've got a question from Alice Wormley for Jennifer on another aspect of the reliability of study findings. She writes, Jennifer, you mentioned a very important point on the need for impact evaluations and the possibility that the survey alone, asking the question, might itself affect people's behaviours. So how can we be sure that people's answers to questions are really translating into changes in behaviours? Are they just saying what they think we'd like to hear? How can we be sure that it's translating into changes in practice and hence child outcomes, as there are some studies that have shown that parent informational type interventions may change perceptions but have no actual effect on behaviour. What would you say to that one, Jennifer?
That's really important. I think in part it becomes a methodological issue. There are certain ways that people try statistically to deal with social desirability and things like that. You can administer measures of social desirability, brief scales where people respond to questions, and then you can kind of control for their social desirability bias. And so that would be one way of handling it. You can also do things besides using self-reports by conducting observations of parent-child interactions, which of course have some advantages in terms of objectivity, but on the other hand, those can be very expensive to do, and you may not be able to observe low-frequency behaviors enough. So those are a couple of methodological issues that come to mind. But that's a tough issue.
Adrienne, anything to add on that one?
Really quite broadly at parenting programs, whether or not they included fathers. And obviously observations very expensive. You can sometimes have teacher reports, your other independent observers, and really it's astonishing how the effect sizes diminish quickly as soon as it's not parent report. And that's not just about fathers, that's just about parenting programs generally.
Cathy, is that an issue that you have come across as well? How do you translate from perceptions and self-reports to actual behaviour change?
Well, what we have been careful to do is to try to build in things that aren't self-reports. So in our RCTs, we're using, for instance, observations of parent and child interaction. Those have got their own problems. But I think this is endemic in behavioural research, this problem.
Yeah. Thank you. Jennifer, another question for you from Melissa on the question of dosage. You said that the BPP was conducted over 16 hours of lessons. Melissa's interested to know, for how long did the parents meet in each lesson and what was the frequency of the lessons?
That was one of the factors that was variable across locations. So local implementers were allowed to structure the 16 lessons in a way that seemed to work for the local participants. So in some cases, they would, for example, have 4 weeks, so where they would meet for 4 hours each week over the course of 4 weeks. There were other places where it would be stretched out for longer than that. So, and unfortunately, we didn't have enough participants who were in specific cells of the implementation timeline to be able to look at whether it mattered, whether they had more intense delivery of the message for a shorter period of time versus spreading it out over a longer period of time. So I think that may be an example of something where in a more tightly, I don't know if I should say controlled situation necessarily, but you could do some randomization of families to different kinds of delivery modes and timeframes, and to be able to evaluate that better.
Thanks, Jennifer. Another quick question for you from Eric. Are there any educational elements in the BPP regarding specifically conflict between parent situations, divorce situations?
There was some of that. It was mostly in terms of harmful effects of interparental conflict on children, and so that was the main way that got brought into the program, kind of the importance of not exposing children to interparental conflict.
Mm-hmm. Thanks. I think we've got time for just one more question. This is from Jill, and we'll go around each of you. Jill says, I'm particularly interested in successful home support programs for children aged 0 to 3. Could you please nominate your favourites among those kind of programs? Jennifer?
I think one for me is nurse home visiting programs. These are the David Olds kind of model where new mothers are visited by, his work has mostly been with nurses, and that may not always work in all settings. And so there's been some work about, well, what happens if you use other kinds of paraprofessionals rather than nurses. But the idea in these programs is that new mothers are visited at home by someone to provide support and see if the family is needing help, and then additional follow-up services could be provided as needed after the home visitor assesses risk for child abuse, for example, and neglect, things like that.
Thanks, Jennifer. Adrienne, same question to you. What are your favourite home support programs for children aged 0 to 3?
Yes, there's quite a, I mean, there's expensive ones like the David Olds, and we have that version here, which is the Family Nurse Partnership in the UK. However, there are quite a number of the programs mentioned in the Panther-Brick et al. Article, of which I'm one of the co-authors, that are home visiting programs, very, very effective with fathers, sometimes with children with autism, sometimes where they train the fathers to then train the mothers. I can't pick a favorite, but there are a number, and you can see them there, and they're certainly worth looking at.
Thanks, Adrienne. Cathy, what are your views on home support programs for 0 to 3s?
I think the question for me is for what outcome are we looking for a home support program? So I think it's important that we emphasize attachment, in which case something like Tulasana would be a really big pick, and those field workers do provide extra kinds of support and get involved in other activities, but they're not primarily there as the nurse-family partnership, which has been shown to reduce child maltreatment. And so for that outcome, that might be a slightly greater favorite, but there are also home visiting programs for children 0 to 3 that provide cognitive stimulation, and that's also incredibly important. So I think we have to ask the question for what outcome, and then start looking at programs that have an evidence base to achieve that outcome. Thanks.
And one very last question, also for you, Cathy. This is from Leonardo, who asks about, can you say anything about the type of violence that's reduced by the Thulasana program? Are we talking about partner violence, physical punishment, verbal abuse? Is it possible to break that down?
So Tulasana is an attachment-based program. Theoretically, it should reduce other forms of violence, because as children will start, it should reduce a number of forms of violence, because the attachment is part of developing empathy for others. And it will give those children a role model for a good relationship, which should influence their choice of intimate partners later on in life. We don't know the answer to that question yet, because Mark Tomlinson is in the field at the moment. Those children who went through the first trial are 13. So he is now starting to look at a wide range of outcomes, including violence in those kids, and hopefully in about a year's time we'll have the answer to that question. So I'm sorry I can't be more specific now, but theoretically it should reduce a number of violent outcomes, child maltreatment to that child because the mum is more attached, and later violence in that child. We don't know yet for sure.
Thanks, Cathy, and thank you, everyone. I think we've come to the end of the hour, so we need to wrap up. But thank you very much to Jennifer Lansford, Adrienne Burgess, and Catherine Ward. Thanks to everyone for listening, and thanks for all your questions. Just to repeat, we will be putting the PowerPoint up on the Bernard Van Leer Foundation website. We'll also be putting a recording of the webinar, and you can get that on www.bernardvanleer.org. You can also download Early Childhood Matters from there if you haven't done so already. So thank you very much, everyone, and we hope to see you again in about 6 months' time.